Thank you very much. So now that you've had an exhaustive introduction to the immunology and T cells around HCV, my job has been made quite easy. So knowing who was in front of me, I left out a lot of the background. But the bit I have added in a little bit to this talk is a little bit of the context, and we can maybe discuss at the discussion point why immunity in Hep C still matters despite the fact that we have curative therapies. So these are my disclosures. If you guys want to turn that down a bit, might be a good thing. And a lot of this work happened in the context of some clinical work as well as a clinical trial that we've been doing in Prince Edward Island in conjunction with V, and those are all of the disclosures up there. Some of the work came with me from way back in the day down in the US. And of course, we have a bunch of participants and persons with lived experience in hepatitis C that we are very grateful to, without which none of this work would be possible. Not to mention the lab crew who actually do all the hard work. These are the folks who have been doing the hepatitis C work. In the middle there is Dr. Sharon Olford, who's the research scientist who leads our lab. And the youngest member of our lab is her daughter, Mila, whom attended her first research day recently at 8 months old. So we're very happy to have her on board already. And as well, picture there is Anna Rosler, who was a Can Hep C master's studentship recipient who did some of the NK work. So I'll touch briefly on the idea of immune exhaustion or senescence and why it may be important, not just in hepatitis C, but in chronic infections, and how that's important to why this matters globally and not just in hepatitis C, I think, understanding these immune changes. A few of the changes we've seen, some of which are very similar to the data that many of the people both on the stage and in the audience have reported, and a few things that are a little bit different. I've kind of approached it from a slightly different perspective, and then the future directions. So chronic viral infections are often associated with immune exhaustion. And that's not true just for hepatitis C, as was just mentioned. This also happens in HIV, as well as cytomegalovirus infection. And good news, about 50% of you hanging out there, looking at the average age, have CMV sitting somewhere in your body and you ain't getting rid of it. So everyone, as they get a little bit older, starts to get more and more immune aging, not just because you get older, but also probably because you've got CMV as well. So the process of chronic viral infection and how it ages your immune system is a pretty important thing, and we really don't understand it a whole lot in terms of its induction. Sure, there's the exposure to antigen, and the immunologist in the room will say it's exposure to antigen, you take that away and the world is fixed. But some things you can't fix, and that includes HIV and CMV. So it's still a very important concept for us to understand. As well, this happens in the context of chronic inflammatory diseases as well as cancers, and in fact, some of the cancers that are now somewhat more palliatable, perhaps is a way to put it, would be palliatable because of the inhibition of immune exhaustion markers such as PD-1 and PD-L1. So understanding where this sits in terms of the real effects of immune exhaustion are really important, and I think that's still a gap in our knowledge despite all the markers that we have and all the phenotyping and some function that we have. So to come back to the immune changes that happen, particularly exhaustive type changes in the context of DAA-associated viral cure. We started out doing this around the same time everyone else did, and we started at a time when we wanted to figure this out from the perspective of, don't forget, this is the first human chronic viral infection that we can reliably pharmacologically cure. There is no other chronic viral infection. Every other herpes virus, everything else that we end up getting chronically as a viral infection, we can't cure. And now we can do this, cure this, and see how much the antigen load in chronic infection actually contributes, and then compare it to other viral situations. So we set out, we know that in the context of Hep C, and we've been over this, so I'll go through it quickly. There is about 20%, some people say 30%, depends on the population you're looking at, 30% chance that after a Hep C exposure, you get an infection and you get rid of it. We call it spontaneous clearance. I like to think of it as a really hard-working immune response that actually does the job. Spontaneous has not much to do with it, I suspect. It's a deliberate thing. And we see viral clearance, and that, which has been known since the late 1990s, early 2000s, is associated with a hepatitis C specific adaptive and innate immunity. And that's important, I think, as well, to understand that even though as virus people who love CD8 T cells and CD4 T cells, my favorite things in the world, it may be that we have to look at other cell types, including NK cells and B cells, to fully understand this. However, in the majority of individuals, as we all know in this room, you get chronic infection, and this chronic infection, in the context of chronic immune stimulation, I kind of liken it to having a toddler who keeps poking at you over and over and over, and finally your immune system becomes less capable of responding after a while. It's kind of like the toddler that you ignore who asks the same question or pokes their mother for the 15th time. This sort of immune exhaustion happens, and you... This is the way I explain it to the med students. You do get some immune exhaustion or aging, but we don't quite know exactly what had happened at the time when we started this in the context of direct-acting antiviral therapies for Hep C that were, number one, curative a lot of the time, and then number two, did not contain an immune stimulatory or modulating agent like interferon. So this was an excellent opportunity to look at what happens in the context of DAA therapy. So what we did was we looked at baseline and at 7 days as well as at the end of treatment. In this particular case, this first data that I'm going to show, and the reason I've left it in even though it's a little older is that I think it has an important aspect to it. It was only one DAA and ribavirin was contained in there, and it was longer therapy, 24 weeks. And also we had the opportunity to see that there was some relapse within this group, so we could compare the two groups immunologically. 30 of the people that were included in this particular cohort for this immunologic analysis had viral suppression at the end of therapy, however, so their antigen load went away, just not everybody cured. We did a bucket load of the usual immune phenotyping with the usual suspects, as well as hepatitis C specific immunity. We took a bucket load of blood. We didn't leukapheresis people, but we did take a good try at making them very anemic, I'm fairly certain, through large-scale blood draws. And as I mentioned, this had a ribavirin-containing regimen. So 35 individuals, and this was some of the panel that we constructed. And you'll notice that there was a B-cell panel that we used. And the reason we did that prospectively, number one, everybody wants to know what happens to B cells because some of the only effective vaccines in the world are humoral based or B cell based. And number two, we knew that in HIV infection, even when you control viral antigen, but you don't cure the disease, there's persistent abnormality in the B cell compartment that might be important and sustained in the context of hepatitis C. So I will zip through some of this data because a lot of it does recapitulate things you've already just seen. The T cell phenotype, and phenotype is just basically, as was mentioned, it's how you look. So there's two aspects to your immune system. It's how you look. You can show up for work and you can look really good or really exhausted, but that doesn't always correlate with functionality and how you do at work. I know I show up post-call and I look pretty exhausted. I'm functioning, but probably not as well as I should. And so because there is variability that's not just linked to how you look, we actually assessed and measured functionality as we went along in a very deliberate way as well. So this is the phenotyping, and this is very sort of streamed down, very basic analysis. Many of the markers that have already been mentioned that are associated on the surface of these cells with exhaustion went down, and this was at day 7. So if it's above the line, it's, this was at the end of treatment. If it was above the line, it's increased at the end of treatment. If it's below the line, it's decreased. However, so that's been shown. You guys are all familiar with that. You were listening attentively in the first talk. But the B cell phenotype is interesting. So the B cell changes that we see in particularly the memory compartment, which you want to have start to normalize, as well as in the tissue-like memory compartment, didn't go back to normal. And on the right, you can see in the pale blue bar, that's a person without hepatitis C, and a person in blue, in the cohort in blue, was the group of individuals who were treated at the beginning and at the end of treatment with antiviral therapy. And the naive B cells, the immature cells, and the plasma cells start to head back towards normal, but the activated memory, resting memory, and tissue-like memory cells stay abnormal. And you're like, great, I don't really care. I'm not a B cell biologist. What does that mean? Well, the take-home message is that those 3 subsets of B cells are important because they're critical for maintaining humoral immunity. And if you're thinking about reinfections and vaccination opportunities, if we get a vaccine afterwards, it's important to know that there's a persistent abnormality in the B cell compartment, particularly if you're developing a B cell or antibody-based vaccine. That doesn't go away even at the end of treatment, and this was actually sustained out to 48 weeks. In terms of how the NK cells look, some of the regulatory markers, NK cells are complex, went down very quickly. And then if you want to look at the hepatitis, so this is just in general. And because we could actually detect these changes, we did note that at least in our cohort of individuals, this wasn't just within the hepatitis C specific cells that a lot of these bystander markers went down. And we don't know if that's related to CMV positivity or not. All of these individuals were CMV infected in the background. So in terms of the hep C specific responses in peripheral blood, I won't show you the liver responses, but they almost directly recapitulate what we found in peripheral blood. This was done by interferon gamma. And what you also see here is that if you have something that's above the line, there were more specific hep C T cells that produce interferon gamma. This is the particular assay we did here at the end of treatment in most individuals compared with baseline. So this is a fold change. However, it's a sneaky way of presenting it because to the point made earlier, they're still the rarest of the rarest little cells. So they're not particularly frequent at this point either. But they do more than they did before. And this is the number of cytokines, which are kind of like your effector, the way that T cells have their effect. They produce more cytokines, at both one cytokine and two cytokines at the end of treatment in red compared with when they were chronically infected. And this was directly at the end of therapy. That was not necessarily sustained quite as much at the 48-week point. And I didn't show you the CD4s. We found something similar. CD4s didn't really change all that much. In fact, the help didn't really help. These are CD8 cells, and they become more polyfunctional, which is that big yellow piece of the pie that doesn't exist pre-treatment that starts to show up post-treatment. And it happens in the non-exhausted T cells, shockingly. Right. So after 24 weeks, which is longer than what we do now, what we saw was with viral suppression that there was some increase in the hep C specific as well as bystander markers of exhaustion. It started to happen as early as 7 days, which is probably a good thing given that we're going shorter and shorter with therapy. And that was without interferon therapy. So we didn't have that external modulation unless you believe that ribavirin is an immune modulator, which some of us may still believe is important. So not only did we have the opportunity, as I said, to look at cure, we also then got to look at the people who didn't maintain viral suppression after drug was stopped. So there were no individuals who had viral breakthrough on drug. This was ostensibly not related to resistance, at least from a virus point of view. But after they stopped medication, within 8 weeks for all of these individuals, there was this subgroup of individuals who relapsed. And in those people, you could see that they did not have an augmentation of their specific responses. And but in the people who did, they started to see a diminution slightly at the 48-week mark. So I think that people are a sum of their parts, and immune systems, it's difficult to look at them when you look at one cell type and 2 markers or 50 markers without considering the whole response that you get. So finding a way of integrating B cell responses, T cell responses, NK functionality, and hopefully someday the innate components in terms of neutrophils, even though they're not directly related. So what we did was just took a quick peek. Instead of looking at the individual components of immunity, what happened if we gave a relative score to each of the components of their immune system pre and post, a relative score, and then added them all up in the people who either relapsed or had an SVR. And we did that for the baseline, so to see if we had a predictive immune type of function. And what you could see here is that our relapsers versus the SVR individuals, if you give them a relative score of pluses, which, gives the quantitative people chest pain and me on occasion, you could see that they were in the 5, 6 mark in terms of their cumulative immunity. Most of the components were weak. In the SVR group, they had a much more predominantly relatively robust immune response, but you couldn't say that it was one compartment or the other. B cell was most important or T cell was most important, and certainly not with these small numbers. And that's what we're trying to do now with a slightly more sophisticated mechanism of analysis than pluses and minuses. So immunity after longer course ribavirin-containing DAA therapy, there was a less exhaustive phenotype, functionally improved cells, and cumulative immune function was associated with clearance, meaning that it might or might not be important. That's not a very definitive statement, but that's as far as you can get with that data. And I think the other people that are in this room would probably agree that there may be some association, but not cause and effect. So ongoing, we're looking at shorter courses of multi-targeted DAA therapy. And we also have this joy of being able to longitudinally follow people and see what happens over time. We're looking at vaccine-associated responses, pre and post, in terms of flu vaccine, tetanus, et cetera, to see if there is true bystander changes. Obviously, everybody with Hep C is not wandering around with influenza, so clearly it's not a marked change, but there may be something more subtle there that we can learn from. We're looking more closely at the B cells and as well comparison with the CMV HIV, and perhaps this might be a rapid and reversible model for chronologic aging that could be useful potentially. So one of the questions that other people have been able to ask more directly, and we did indirectly, was, do you think that if you have a decrease in immune senescence and in vitro immunity, that could translate, an increase in vitro immunity that translates into less reinfection risk? We weren't able to directly ask that question, but what we did do was go to a place called Sleepy Hollow. Not this Sleepy Hollow, this Sleepy Hollow, which is a correctional facility in Prince Edward Island. And we went there because it's an island. Not a whole lot of going in and out, except into and out of the correctional facility where there's a whole lot of going in and out. And we found some people in there who had hepatitis C who were still at very high risk for exposure to hepatitis C, treated them with a 3-drug regimen for hepatitis C, and then assessed their immunity pre and post. And the reason this was such a good opportunity, number one, to compare with the other population we had studied that were older, long-standing chronic infection, and that they had genotype 1, this population was mostly genotype 1. So again, some comparability. Number 2, they were young. And number 3, they had an estimated duration of infection, which was quite short, as well as some ongoing risk factors. So the ability to look at things a little differently compared to the other. This was our study design. And we've had a lot of challenges with doing a correctional study and research in a correctional setting. I think it's important to do it, but it's challenging. And just to briefly give you a sense, the basic science question I've already mentioned, and could exactly right after you've cured someone be a good time for vaccination if you ever came up with a vaccine. So in the 17 people that we've looked at so far, and we're still recruiting, about to recruit more people now, again, different population, younger, shorter duration of therapy with recent risk factors in the form of injection drug use. We didn't see the same thing. So I've shown you here CD8 cells and B cells. At the early time point, there was no change. And in fact, the people who were chronically infected for a short period of time, generally less than 3 years, but the range was between about 5 to 6 months and 3 years, we didn't see that they were any different than people without hepatitis C in terms of the CD8 phenotype, at least, and the B cell compartment was not as skewed. Again, suggesting, as has already been mentioned, that shorter duration of therapy or shorter duration of infection may actually be a less imprinted and comprehensively exhausting process. So not all people are the same, and not all time points are the same. And funnily enough, immune systems are complex and probably need to be studied in individual populations and taken as a whole. So does it still matter? I said I was going to talk about that briefly. I think it does matter. I think it matters in terms of people who have lived experience and have ongoing infection with chronic hepatitis C. It matters. And it matters in terms of perhaps vaccine responses, and not just for hepatitis C vaccine. I think it matters to understand it from a public health perspective, whether there are subtle changes at a population level in terms of responsiveness that we haven't quite identified yet. Particularly as people are getting older, your potential for responding to vaccine is very different, and that may be an important cofactor. And then in terms of the hepatitis C specific immune function and exhaustion or lack thereof, I think that becomes a very important point for the development of a vaccine, which, again, I hope I'm not having to convince anyone in here that we still need a vaccine. I think we do. And then there's the clinical connection. There's all kinds of other conditions that are actually linked to immune exhaustion. And we talk about it, and it's like the cytokine storm of sepsis, right? We don't really get how we get there, exactly how it happens, and we need to understand that process of pathogenesis and reversibility in order to be able to fully reverse it and understand it as we go forward into other disease conditions, which are actually important to people health. And we're not just about hepatitis C health, we're about people health and looking after people. So chronic fatigue, well-being, all have been linked to immune exhaustion states, as well as cancer. And guess what? Cancer already has a whole bunch of therapeutics that are approved and on the market that we might be able to utilize as adjuvant therapy for immune stimulation. Wouldn't that be nice? As well as in inflammatory conditions like IBD, very common, particularly in first world countries, and immune exhaustion and poor responsiveness to vaccine is a thing there, as well as in the context of chronologic aging. And I got bad news for you, we're all aging. So figuring out this immune exhaustion thing might not be a bad idea. So it's important for people who have hep C, I think, and it's important to understand it even further and continue the work that everyone here on this stage is doing, as well as in the audience. Because we might end up with a reversible model of aging that's actually helpful, not just to people with hep C, but to the general population. So thank you to everyone in the lab who did all the hard work, and I get to wander up here and talk about it. And we'll probably take some questions.